Let me just start with our panel discussion. And the first question would be around risk stratifications as a future screening concept. We read a lot about this, you know, and there are recommendations every 2 years, depending on the country you are in. And I think risk stratification shows some future potential to make the existing programs more cost effective that we had. And my first question is circling around this. And I would like to start with Dr. Iotti. I know that the region, Emilia Province, is really taking part in the recruitment of this MyPBS trial. And if you could just elaborate a little bit, what are the reasons why you believe that risk stratification is advantageous for breast cancer screening, or just tell us more about the objectives of this current trial?
Yeah. Thank you very much also for really the kind invitation. And I am pretty young, I can say, okay? Also from the radiological point of view, and in these few years I saw so many interesting tools coming into this breast scenario, breast imaging. And maybe the idea is not to be so enthusiastic about the tool itself, but to understand how to implement it as best as possible for each woman. So the idea is that MyPEBS also is a prospective trial, European, so it means that it takes several different countries with different screening setting, and it's founded by the from the European Union, and it's an open label, multi-centric randomized trial. And the target is to understand if stratification can be reasonable and sustainable, because we are still talking about not only indications but population-based screening. It means that it is an offered by the population to be open for everybody who needs it. So it's not only I suggest you, but I give you the opportunity to take part of this. And first of all, the first target is to assess the risk. It's not so easy. Few hours ago, we just had an interesting session about the risk assessment. So it's not so easy to fix it, to understand how the risk is for each woman. And for this trial, they took into consideration women excluding from BRCA1 and BRCA2, that it's another a different pathway at all. So they took into consideration age, that up to now is how risk screening is indicated and for each woman, and put into together age, personal items like hormonal, reproductive situation, lifestyle, and also SNPs, that is something that just came into this field up to now. That is just some polymorphism, some nucleotides that if there is an alteration, the cumulative incidence of this alteration may affect the risk of breast cancer. And then also breast density, that I am sure it will be also an issue for the next questions. So that the reason is just to understand how often and which kind of tool should be offered to a woman according to her own risk. So the first step is to assess the risk and then to follow them for 4 years with this experimental tool. We have 4 class risk. This is just a low risk, normal, intermediate, and high risk. And the idea is to offer them mammography or digital mammography or digital breast tomosynthesis, plus ultrasound if needed, plus MRI if needed. And the idea is also to reduce harms in people at low risk. I mean, also false positive, recall rate, and all the anxiety that is linked to this is a part that can be a damage for the people, also for the reattendance to the subsequent rounds. So to limitate the incidence in that kind of population could be also helpful. So it's a 360 degrees of changing the perspective of proposing tools and frequency for the breast screening.
So, Dr. Iotti, just a quick question. You mentioned SNPs, SNP, single nucleotide polymorphisms. Is this part of this study that all women are assessed for certain SNPs? So you have the traditional imaging part, I would say. Then you have the genomic part, and you try to put this all together to come up with an individual risk score. If you could just elaborate a little bit on that.
Sure, sorry. There is not only, there are several points. SNPs are taken from a saliva sample for each woman. So we have a genetic assessment. Then we have the breast density assessment for each woman. And then we have also a long questionnaire just looking for the lifestyle. That is another part that is not really so linked to the genomic nor to the breast density. So it's based on two different risk models assessment. We have Tyler-Cuzick for women, for the general population, and for women that have just one relative with a breast cancer or ovarian cancer, and then Mammorisk, that is another model for people without this. So the risk will be assessed taking into consideration all these characteristics of each woman, of each person that is really a word to assess.
Thank you very much, Dr. Iotti. That's highly interesting. Now moving to the, I would say, the Greek perspective, Dr. Vourtsis, why do you believe in risk stratification? Why do you think it is so important? If you could just elaborate a little bit on that, and which is the main issue you see today with this one-test-fits-all screening programs? Because when you look at the literature, not everyone is so in favor of that. If you could just elaborate a little bit on your perspective.
Thank you very much for inviting me. I'm happy to be part of this very nice panel. So it has been very well acknowledged nowadays that mammography is not suitable, and not all women have the same benefit from mammography. Not all women have the same sensitivity. Therefore, it is important to recognize the influencing factors that may affect the benefit of mammography and also the sensitivity for each woman. Therefore, by recognizing the influence factors, which is the age, also the breast density, the family history of the woman, and prior biopsies will help us to recognize which woman has a higher risk of developing the disease. And this is very important because if we understand and we can separate which woman has a high risk, then we can guide supplemental screening, and we can give some information, more information, inform physicians and women about other options about supplemental screening. And we know that supplemental screening, apart from mammography, is beneficial because many women, by adding additional imaging as breast ultrasound, handheld, or ABUS, we have additional cancer detection. We can detect 4 to 5 cancers additionally. And also women that have even higher risk, more than 20% lifetime risk of developing breast cancer, by adding MRI, that have a high risk, they have a great benefit in detecting important cancers that are very aggressive, so their prognosis which will be much, much improved. And I feel that especially from this conference, that breast screening tends to transform from one-size-fits-all to more precision medicine era, where decisions about screening will be taken into consideration according to the risk factors, on how frequently we'll screen, what modality we'll be using. And this is not far away from the near future. It's just a matter of time once we have the results from the MyPEP study that we heard just now from Dr. Iotti, as well as the Wisdom study and the DANCE trial from the Dutch trial. It's just a matter of time, I believe, to just proceed.
So that means the one-size-fits-all approach is probably not the approach for the future. So it's more like an optimized strategy, right? Based on individual women. I understand. So thank you very much, Professor Frauenfelder. So now moving to Switzerland. Switzerland is a beautiful country, but the regulations are sometimes a little different, let's say, from the rest of Europe. So I would be very interested in hearing your opinion in general on risk stratification and what are the regulations in Switzerland. I'm just curious for delivering breast cancer screening. If you could just tell us a little bit about it.
Well, yeah, I'm not sure if we're in a good or in a poor situation about this. Well, I feel it is a good situation for us. No, in Switzerland, it's, we have different cantons, some very nice cantons with many snow and some are more in other side. And each region has their own system. One have the French part has, since long time they have screening. We in Zurich, we don't have. You may heard in 2015 when we had New England Journal, also in the New England Journal, it was published that Switzerland will not have screening or this guy because the favor of screening is not that well. And I think it's something, if you look at screening, yes, screening can have positive and negative side effects. So the effect of having 1,000 women screened, one will maybe survive 3 to 4, this number. You can debate on this. I think the screening, what it is to, and this also comes over to what we now say, has to be more precise on which patient should we screen and how should we screen. And we in Zurich, we have the good thing is we have a opportunistic screening. And this gives us many freedom. We get patients just from mastodynia or a feeling, it's not age-based, it's just a patient who thinks, okay, I'm not very comfortable, I want to have. And then it's our decision what we want to give this patient for the best opportunity. And this is also where we have the freedom in doing studies. We can say, okay, we use mammography, we use ultrasound, when we use ultrasound, when we use MR, there is no regulation at our side. We can use standards which are given by the Leitlinien or whatever else. We can use them, but we're not forced to. We can interact with the patient, and we, compared to other screening situations, we see the patient. Each patient we personally see it, and we can feel the harm which is coming out of this patient, and see, okay, no, I can go more aggressive. I should be more a little bit back on this. So this is the situation we are facing. So I'm not very unhappy to have not regulated screening. So this gives us a little bit more freedom in what we do. And also in perspective of what we do for study, she mentioned breast density. We have a study out there where we did breast density measurement with new method on ultrasound, sound of speed, for example. Or we now use also the ABUS. When should we do follow-up of which lesion at which time frame? When can we say, okay, this lesion is no further need of we can skip it, or should we do more follow-ups? And this gives us these possibilities.
So, Dr. Vourtsis, you already mentioned quickly supplemental tests like tomosynthesis and ABUS, and you also mentioned them. So this would be my next question to Professor Frauenfelder. What is the added value of these supplemental tests, especially in women with dense breast? And if you could just tell us a little bit about the reimbursement situation. I mean, are women willing to pay out of their own pocket for those tests? But especially if you talk a little bit on tomosynthesis and ABUS, especially in dense breast.
Well, first of all, tomosynthesis is not our favorite tool, add-on tool. Because we say we have mammography, we see the calcification, and our favorite tool, and this is why we also switched to ABUS, is really ultrasound, the additional part. We see mammography and ultrasound complementary. There's a second part is the MR, if you would add this, and this gives us the whole picture is ultrasound and mammography. We use tomosynthesis, but not more often than spot exams. It's our situation. For the reimbursement, what we see is that, and this comes from the opportunistic screening, I think that we see other type of population than might be in a screening population. We see patients that are aware, that know the literature, they are also a little bit more educated, and also the doctors in behind, they have much more influence. Because the patient goes through a gynecologist to us. So there is some kind of a filter which comes in to us, which is maybe not in other situations given.
So what is the typical workflow in your hospital that you have established for women with dense breast? If you could just a little bit talk about that. Do you have like a standard workflow?
Well, it's not so standardized. We have, first of all, age, which we use. Patient under the age of 35, as given, will never go directly to mammography in our department. They start with ultrasound, and then we decide mammography, yes or no. And the other thing is also patient that we had from, well, has to start otherwise. The gynecologist often do ultrasound in addition, and they see, okay, there is a lesion or whatever else. So we have not a straight mammography, then ultrasound, and then MR, but we have more often also the patient directly to ultrasound, and maybe we don't use the mammography. We then maybe also go directly to the, we bypass some parts, and this gives us the possibility to manage the patient on what we see on the ultrasound. It can be that we do afterwards a mammography, yes, but it is not always a straight line going through.
Thank you very much, Dr. Vourtsis. Could you give us a little bit more information regarding breast density and the associated risk, and what are you doing, like in your clinic, to tackle these challenges in patients with dense breast?
Yes. So we must understand that breast density is a normal situation, and it's very frequent because most women, 50% of women between age 40 up to 70 have dense breast. And the reason the breast density became very popular. Is this global? This is globally, yes. The reason this entity has become very popular nowadays is because of the important clinical implications that it has. If we compare women with fatty breast compared to women with dense breast, we have realized that women with dense breast have a lower sensitivity in mammography, have a lower positive and negative predictive value, lower specificity. Also, there is an increase in the interval cancer rate. And there is a question still, because not enough work has been done yet, regarding a decrease in the mortality rate from screening. So taking each implication separately, the reason dense breast is very important is, and supplemental screening is very helpful, is because the X-ray attenuation in women that have dense breast is very similar to breast cancer. Therefore, you have to compare one white that's adjacent to next white, so we cannot distinguish cancers that have developed in the breast and they're not associated, they don't develop with microcalcifications. And this is called the masking effect, which causes actually the interval cancer rate, the high interval cancer rate. And this is very important because those cancers are invasive cancers, they're aggressive cancers, and the prognosis in these patients is not as good as the ones that appear with cancers with microcalcifications. Now, regarding the mortality rate, there is a study by Dr. Chu that has shown that women that have dense breast have about 50% less decrease of the mortality rate. So this is also an important issue. Now, I'm working in Greece, I'm working in Athens, this is where I'm based. I'm working in private practice, and in Greece we don't have a national screening program, so we have opportunistic screening, just like you have in your country. And this gives us a great opportunity because we can tailor breast imaging according to our patient's need. So we perform ABUS examination in all women that come to our center and are having dense breast C and D, breast parenchyma. So this is our first line examination that we perform. And if a woman is over 40 years old, then we supplement mammography. We perform mammography, not supplement mammography in addition. However, we perform ABUS first because we have the time to review the images while our patient is in the mammography suite. We perform usually MLO view on mammo, and we tailor with CC view and with tomosynthesis. So it's one view, MLO 1 2D, and one view is CC with tomo. And if there is a finding either in mammography or in ABUS, then we perform handheld as a second look ultrasound examination. If there's a suspicious finding, then we proceed with a biopsy. We try to give the results the same day, so it's from the time the patient comes in, the patient leaves, the downtime is about an hour.
Just a quick, regarding reimbursement in Greece, can you just
Yes.
tell a little bit about
Well, this is from private insurance, yes, so this is private. So patients get reimbursed, most of them, from, there is an examination going on, I hear a Doppler.
It's a Doppler, but it's not
Yes. So most, yes, in our center, it is private, only private. Some patients get reimbursed from private insurance, and others pay from out-of-pocket money. Thank you.
So, Dr. Iotti, we have heard from Professor Frauenfelder that he's probably not the greatest supporter of tomosynthesis. Please, it's correct. So, however, yeah, right. And you were PI, principal investigator of this huge study in Italy, and I know that by including tomosynthesis into the study, you detected more cancers, and the recall rate was lower. So obviously, you're a supporter. You like it. So please try to persuade Professor Frauenfelder why tomosynthesis is the way to go.
I do. Okay. Well, the idea is that basically the setting is a little bit different. Okay, so we started this study in a population-based screening, and in Reggio Emilia we have 9 radiographers that work with an amount of 50 exam per hour. So it could be impossible for us to perform ABUS to everyone. So we enrolled 27,000 women, and they've been divided in 2 arms, one with full-field digital mammography, the standard one, and the study one with full-field digital mammography plus DBT. So we just discovered that among this population, we had really an increase in detection rate that compared to the standard one is about plus 68%. So we have a 7.6 per thousand in the study arm versus a 4.5 per thousand in the control arm. We did not consider the prevalence round. So all the women we enrolled had already had one mammography, but because we know that the very first time that someone performs a mammography, we can find a whole world. So we excluded these women and just took a screening population. And the increase in detection was significant, really significant. And without an increase of recall rate, that means that we had 3.8 in the study arm versus 3.9. So more or less the same, but it's correct because we found more cancer. So the positive predictive value also was really higher, plus 70%. So it works. And there are some studies, I don't know if they are true, that say that if we would had for all these people also ultrasound, we would have a huge increase of false positive so an increasing record rate. And as we said before, it could be considered an harm of screening because these patients are scared because of our uncertainty. And so DBT could be really a great tool. And we observe that this increase is equal for each breast density category, also for category D. That is just only a 10% of patients, more or less, but it is truly a nightmare. So I understand that when I see that, I would like to have an ultrasound, but also DBT is really performing really good. So I do agree, DBT is worth it. So and can be and can be implemented also without changing all the structure of screening in a public hospital like we are.
I'm looking at Professor Frauenfelder, and I think he is giving a DBT a second chance, probably. No, I mean, I don't want to get it wrong, but maybe you can just elaborate a little bit so that I don't say anything wrong. I mean, you appreciate tomosynthesis, but it's not routinely used in your routine.
Well, we have a different situation, I have to say. We have a patient opportunistic screening. The patients are used, or most of them know, that it's not a screening like in a systematic screening where they go in and out and it's done. They don't see any doctor. They want to be cared about, taking care about them. This is what they come. They also referred for this. They are personally referred to me also for that. This gives a different situation. This gives more or less the same situation like in Greece where we have private practice for this situation. We are in public. But it's also a matter of time. How much do you want to get through in which time frame? And I think in this situation it's different. I have the possibility to decide on each patient, yes, I do an ultrasound, or yes, I do not, or I do a spot, or whatever I do. So this gives me much more flexible, and then I think it's the situation which makes the difference.
Could I just comment? Absolutely. Could I please? Yes. Yeah. Because I'm in between my two friends.
That's why you sit in between.
Yes, I think the reality is somewhere in the middle. So I've been working with DBT since 2011, so it's 7 years now, and it is very helpful from my experience for ACR, A and B breast parenchyma, also for C, for detection of architectural distortions. But the major issue with DBD is that circumscribed cancers are obscured in D parenchyma. And I have many examples that we have performed DBD, and there's even palpable findings, 3, 4, 5 centimeters of size. And DBD, even in retrospect, we couldn't see in D parenchyma the cancer. And we're talking about large tumors.
I thank you. Now we are moving a little bit from imaging modalities to awareness and education, which obviously also in breast care is a crucial piece of this puzzle. And I know you are very active in the Dense Breast Info Europe organization. So to actually raise awareness amongst women regarding screening. Can you just share with our audience what is the organization doing, what are you doing, what are your goals, and maybe you can share some results already.
Yes, thank you very much. So because there is a high diversity in Europe on breast awareness, we felt the need that more information was needed, and we launched the expansion of the densebreastinfo.org last October in Greece, in Athens, during our USOBI meeting. And the aim of the expansion in Europe is actually to educate as much as we can healthcare professionals about the clinical implications of breast density and the value and impact of supplemental screening. And currently, this is the densebreastinfo.org is the only website that is medically sourced research with important information for both healthcare professionals in the States and women, and healthcare professionals in Europe. So in Europe, the website that we have developed has been developed specifically for healthcare professionals. And in addition, there is a CME credit that the topic is on dense breast density, why it matters. And it is accredited with 2 AMA points. Yes. Thank you.
Professor Frauenfelder, I know that the Canton Zurich is offering personalized breast care, and now coming to this education, awareness, and communication piece, how do you communicate this to your patients? What is your take on that?
Well, this is somehow difficult because what we see is that the women get a little bit tired about screening and about care because they see, okay, every year something, and what we try is we mostly use the modalities to get them aware, because then we have a platform where we can go out and say we have new advantages. For example, when we implemented ABUS, when we had sound of speed, or now we have also Mammography, which we use, for example, in our institute. And what we just saw recently with the implementation of the breast CT is there was a quite huge impact on this, because it was new, and also it came into the public press. They take it up. They took in the female news journals, and they come up with this, and this gave an awareness about this situation. Yes, I can have alternatives, choose, I can use compression-free mammography and so on. And the interesting part was now that not only we had more on breast CT patient, but also on mammography, it increased. So this was a combination which we was not thinking about before, but now we have both increase. We now have new breast CT, but also mammography itself. The patients get an awareness about this and can say, okay, I want to have this. There's now written in the newspaper, they listen, read about it, they hear about it in the television or so else. And this had a new possibility for us. And what they see is that it's diversity. It's not only screening like this, so they see it's different possibility. And we have the other thing is the ETH is close to us. ETH also propagated new stuff on ultrasound, sound of speed and so on, for cancer detection. And I'm going now a little bit forward, but what will be the research is on our side is not, we cannot do the studies on primary detection or not. We have not this number like you have in Reggio Emilia, this we don't have. But we now focused much more on the process, when is something there? What would be the best way? When can we, or how can we better go from BIRATS 2 to BIRATS 4 and get this BIRATS 3 as less as possible? This is our main goal in our research which we perform at our hospital now.
Speaking of mammography screening, Dr. Iotti, and I know about the challenge that countries offer mammography screening, and then the compliance is very low. Women don't, use the offer; they don't do it. And I know that you've worked extensively on a new technique, the patient-assisted compression technique. I know that women know their breast best, and when you ask them to compress, they probably compress more than and that translates into better image quality than as compared, a technician is doing it. And can you just share some results of your work, because that's very exciting, I think.
Well, actually, indeed, in Reggio Emilia, we had a high attendance also for our screening, more than 90%. because anyway, the education of the last year passes and all people are pretty comfortable anyway. So we decided not to prove this patient-assisted compression in a screening population, but to move from the small amount of opportunistic screening that exists also in Reggio, and for among women with a personal history of breast cancer, so breast cancer surgery on the breast that is more painful if compared to a non-surgery breast, and also among women of high risk, familial risk. So these three kind of women are what we analyze in the clinical setting. And they tend to be more anxious than a screening woman that is asymptomatic. She's fine. So she just had this mammogram and then just go away and life goes on. They are more stressed when they come and they have to meet a doctor. So maybe it's different population anyway. And we just use this device that have been developed just to allow a remote control on the compression, and that given to the patient, it allows a self-compression. And this involves the patient in no suffer from a mammography, but to be active participating in that. And we, again, had a randomized clinical trial, 2 arms, and 500 women enrolled, 200.5 and 200.5 in the 2 arms. And in the study arm, where they used this device, they were first positioned by the technician, and they achieved a compression up to 5 decanewton just to be sure that the breast could be fixed and that the quality of image would be sufficiently high diagnostic. And then we asked the patient just to compress, if possible, up to 10 decanewton. That for us is just the optimal level. And the incredible thing is that they really compress statistically significant more, really, because they were involved in this, just it was a challenge. Who will be compressing most? Also among each other, because they were sitting outside close, and so how much did you achieve? Yes, there was something like that. And they entered the room saying, I achieved 20. Wow, so almost died.
Better image quality time.
It actually, not really, because, the image was not worse, for sure, because it is linked anyway to thickness. So also, if we achieve a higher compression, it not really correspond to a thinner thickness beyond a certain threshold. So dose and image quality is linked to thickness. But we had a blind assessment by 2 radiologists and 2 radiographers that assessed that all these images were really optimal level, and they were almost perfect. Also because both the radiographer achieved a compression level of more than 10 decanewton, it was 10.2, and for the control for the study arm, so the women reached up a medium of 12 decanewton, so they were really great. And it was funny anyway, they were involved, and it was really a great feedback from them.
Now that's really a great results, and let's move a little bit to future research and future technologies. And you probably know that GE Healthcare is investing a lot when it comes to breast care, developing new techniques and stuff like that. And I know you are a fan of contrast-enhanced mammography, and that's very interesting. So let me ask you, where do you see the role or a potential role of contrast-enhanced mammography in this, let's say, breast care journey? What are possible indications? Does contrast-enhanced mammography have a role in screening? If you could just tell us a little bit about that.
Sure. Well, I do love contrast mammo, so I will be a little bit biased, but up to now we can see that it performs as MRI for neoadjuvant chemotherapy and for treatment monitoring, that means also for pre-surgery stadiation. So it's really good. Numbers are not so robust, but the trend is it's already a possible alternative to MRI for this population. It has been recently proposed as first line in symptomatic women, because anyway, the low dose image of the low energy image of contrast mammo is equal, if not superior, to a normal full-field digital mammography, and the recombined image allows to explore the contrast enhancement of breast structure. So it has a lot of information in a single examination. And so I think that we can see, we can wait for some years to be more robust in the symptomatic women. About screening, I do believe that screening really has a lot of tools. And as a doctor, we have to, as a radiographer, we have to guide women and propose them the best for them, and not let them just, among several possible tools to choose, and not really knowing what the best is for her. And I think that there is a challenge that contrast mammo could be useful in high-risk women, because right now there is the indication of a contrast examination like MRI. So the risk of a contrast injection is already considered for these women, and beneficial that we can gain from this are higher than the risk. And there is a paper recently published by Sorin that showed that contrast mammo in this kind of population has a 13 per 1,000 more detection rate if compared to full-field digital mammography. So it's really high, and it could be justified in the future for these women, just mixing together the benefit of a mammogram and enhancement in one single examination, and fast one.
I think we all can really tell that you really like contrast mammo. So now I'm looking at Professor Frauenfelder again. So, but I know he likes really ABUS. He likes ABUS, I know that. And there is a future prospective trial you are planning that heavily involves ABUS. And look into your eyes, and so I see you're smiling. So tell us a little bit about the role of ABUS, probably in general in the screening journey, and in this future trial you will be conducting in Zurich.
Well, the general role of ABUS, I think, is that we get more information out of this volume. We have had volume data, and I hope that we get out of this data more information. We are also very keen of using AI in every situation where we can. So this, I think, is a new possibility which we can get together with this information. And in our study, where we use now MR as the standard of reference, I think this ABUS helps us. I hope that ABUS will help to manage the patient quite early in the right direction, using this reformed, coronary reformed or whatever reformed image to get much more information out of this volume. And I think this is the great, when I wanted to use ABUS, this was my initiative, was because I'm a CT guy. So I like volume. And this is the reason why ABUS was for me always very nice to have. I can work like on a CT, and I think this is what we can really take out of this method as a great advantage. We have all directions, every position, we have volume, and we have also structure information. And this, I think, is what we will also show, that this is really an advantage for further, not for screening, but for stratifying the lesions. As I mentioned before, our goal is not screening itself, because we are not a large population, we don't have this large population. Our goal is the further stratify or the management of lesions. And this is what we think there we can have ABUS has further impact.
Thank you very much. You mentioned artificial intelligence, and if I look at the scientific program of this year's ECR, there are 44 scientific sessions with 317 presentations on AI. I mean, this is really, really incredible. It's not science fiction, it's science fact. I mean, it's there and it will stay, love it or hate it. And Dr. Vourtsis, I know that you are also using or integrating AI into this breast care journey, and you are an advocate or also to integrate this. Maybe you just tell us where do you see the role of AI in personal breast care? If you take a glimpse into the future, where will we be in 5 years with AI and breast care?
Thank you. So in the past year, with my collaborator from Portugal, Dr. Papanikolaos, we have been closely working together in training deep neural network with transfer learning methods in differentiation normal from abnormal breast tissue, and our results are very impressive. We have a very high negative predictive value, 99%, and the area under the curve is at 0.91. And these results are, we have an abstract during this conference where we are presenting these initial results. Additionally, we have developed a radiomic signature for differentiation benign from malignant breast lesions, and we present these results during past USOB in Athens, and we had an accuracy that reached up to 80%, and when we added the radiological BI-RADS classification, the accuracy was elevated and increased up to 90%. So the results are very promising, and from my point of view, I believe that AI will actually empower radiologists because it will help us improve and optimize our workflow by increasing the accuracy, decreasing the false positive, decreasing the cost of breast imaging care, and therefore we must try to adopt AI in the future and to keep without abandoning the personal factor, which is very important to both patients that are and physicians that are anticipating in breast imaging treatment and diagnosis. So concluding, I personally believe that AI will be the future. It's here and it will stay here. And our best option is to be educated about it because it will help us proceed in a better way. Thank you.
I'd like to echo that. I mean, this is exactly what my opinion is. Maybe we are all biased because we are radiologists, but I mean, we have to see it as a helping tool to make our lives easier, to probably get rid of routine or easy tasks, and just to integrate the enormous data, not only traditional radiology data, but also omics data, to diagnose disease more accurate and faster. I think this even will empower us to humanize or rehumanize healthcare, because it frees up some time, and we can take care of our patients again. And so I would like to open the discussion to the audience. We have a couple of minutes left, I guess. So if there are any questions from the audience, you have the opportunity here with our three fine panelists. Please, are there any questions from the audience? Any topic, off topic, whatever you like? But, okay.
Straightforward. I wanted to have your point of view about the time to read that the radiologist has to dedicate to this type of exam.
Thank you. Yeah, actually, in our situation, but it's almost the same in all the published results in the literature, the time to read screening DBT almost doubled. So it's about plus 50, plus 60% of time. But the interesting stuff that we discover is that this is true only if we consider negative mammograms or negative DBT. If we have a recall, then the reading time is almost the same if we compare a suspicious mammography and a suspicious DBT. That means that DBT is easier. It just pops out in a easier if compared to a mammography. And that the increased time is mostly due to a higher number of images to assess. So that's why we also studied a sort of simplification protocol, trying to play with the thickness of the slab or the planes we analyzed, because there are different possibility of reconstruction from the raw data. Very thin planes, that means 1 millimeter, or thicker slabs, about 1 centimeter. Slabs will be easier, faster to read, but the wording is that we can miss those tiny speculations that are visible only on the planes. That's why planes exist, because it allows to a better, more specific, especially in dense breast, analysis of the breast tissue. So we had just this first analysis that sparing 20% of time in reading, we just had just a slight decrease in sensitivity. That in screening setting is not really that good, because it means to miss cancer. So we surely have to work further for this to find the perfect thickness of what we are analyzing with DBT. Thank you for the question.
Are there any more questions from the audience? If this is not the case, I would like to thank you very much. First of all, I'd like to thank the 3 panelists, and I also like to thank you, the audience, for attending this breast care panel, and you all have a great ECR. Thank you very much.